Morning, Jeff. How are you today?
Good, good. Long day in America, but I
Yeah,
hope you have a good start to your day in Australia.
yeah. Thursday morning here. Thursday morning, the 9th of March. What's your time zone? Where are you at?
I'm in New Jersey, so Eastern U.S. time. It's 6:30 here.
6:30 p.m.
hmm
Wow. What did you get up to today?
I started my neurology clerkship this week, so I'm on my
Oh,
third day on the epilepsy service at our hospital.
fantastic. Okay, well, can you introduce yourself to our listeners? Yeah, how you got in touch with us and how we connected? Because
Yeah, so
I'm a bit curious. I'm a bit curious as well. I can't remember how did
yeah,
that all pan out?
I'm Jeffrey O'Malley. I'm a second year medical student in the U.S. I found out about CrossFit Neuro through my father, who got very into CrossFit during the pandemic, set up a whole box in our garage, basically. And he's been very into all the CrossFit podcasts and literature. And he sent me, one of your talks that you did on CrossFit and one of your uh, podcasts you did with Dr. Fauché. And, along those lines, definitely have enjoyed reading and listening to your talks and all of your perspectives on spinal neurosurgery.
Fantastic. So your dad's a CrossFitter. What about yourself? Have you embraced the sport of fitness as well, or who
Definitely.
was first to get into the sport?
I think my dad was first to really get into it. I always kind of dabbled in the exercises a little bit
Hmm.
while I was in college, especially my senior year during COVID when I had a lot more time on my hands to actually do stuff. But now during medical school, unfortunately, I think I've cut down a little bit, just kind of been driving all over the state to get to hospitals and long hours and stuff. So it's been a little difficult, but I definitely need to get back into it.
Oh, brilliant, brilliant. And you've got your dad's got a home CrossFit sort of setup, has he? Is he-
Yeah, he took over the garage. We put some horse stall mats down in the garage. We have a half rack pull up bar, too many
Yeah,
plates. We have two bars
yeah,
now. Added a box jump. We have just about everything. He's got
wonderful.
it in the garage. So
And does he still train at an affiliate, or he just does his own sort of programming at home and trains at home?
yeah, he just does his own programs at home for the most part. He does a lot of
Mhm.
the end of three fitness programs. If you're familiar with those.
Yeah,
Um,
absolutely. Yeah,
yeah,
you can just look up any workout and go, I like that one. The
yeah.
danger with that is that you just keep doing the things that you're good at and that you like, and not do the things that you're not good at.
Oh no, he definitely gets good variation in, and he'll be out there for hours. It seems like.
Yeah, what is the saying? Deficiency determines demand. Uh, Make sure you tell your dad that the things
Yeah,
that you're not good at, that's the stuff that you've got to do.
yeah,
Um,
exactly.
right one, and you're in second year, are you? Second year out of how many? Four,
Four.
4 year course. Okay. Um, and is that a undergraduate? Like, have you already done a degree or qualifications?
Yeah, so I did my undergraduate degree at Boston College and then matriculated into med school after I finished. So I started in 2021
Hmm.
was my first year. And then we wrapped up our preclinical, so basic science
Yep.
knowledge in November of this year.
Righto.
And then we've
Yeah.
been in the hospital since.
Yeah. And what's your undergraduate qualifications? What have you done previously? What?
I did economics, actually. So I
Okay.
wasn't a science major. I had a minor in chemistry,
Hmm.
which I really enjoyed. Took a lot of NMR classes, which is really the foundational principle of MRI, and I really
Okay.
enjoyed that. So good to know all the science behind that.
Sensational. All right. And what sort of aspirations moving forward? Like when you graduate, where do you want to be in 2 or 3 years' time working, and in what sort of subspecialty?
So 2, 3 years from now, I hope to be in my neurosurgery residency. I'll be applying in I think just over a year, year and a half. Will be the whole application process, and hopefully 2 years from now, I'll be able to say that I matched into a neurosurgery residency with the way the
Wow.
American program works.
Yeah, that's tough. I've had a few. I've mentored a few medical students, throughout
Mhm.
their medical degrees, and I've actually one of my very proud to say one of my prodigies, so to speak, is now he sent me a message a couple of years ago, and he sort of said, "Yes, I'm a neurosurgeon," and he's a very, very dedicated fellow. And we have a few
Mhm.
medical students in our box at CrossFit Neuro,
Awesome.
and they're superb, superb people, and really understanding some really fundamentally important aspects of health and fitness, and hopefully that's going to transfer to their mindset when they become clinicians as well. So I'm always really delighted to talk to people like yourself, because we've got to be realistic and take accountability for our current levels of health, which is,
Mhm.
given our affluence in modern societies, it's really disgraceful that we have such terrible statistics when it comes to chronic disease. Where two-thirds of the population are overweight or obese, um, and the rates of diabetes just climbing through the roof, and all of the other factors that fall under that umbrella of the metabolic syndrome, or syndrome X, or insulin resistance, really. Um,
Mhm.
because the profound thing is that it's so easy to reverse. Like, it's so easy to make a change. And for many years, I was kind of scratching my head as to why governments aren't doing more, and the guidelines aren't doing more to improve on public health. And you know, doctors have to drive it. We really have to do more to drive public health. So um, I think it's wonderful that there's people like yourselves who are embracing CrossFit. And um, don't you think it's profound that a little old sport like CrossFit is kind of setting the roadmap for
Mhm.
global health policy? Um, but it won't change unless we, as clinicians, start to really guide our politicians on
Mhm.
how to do things correctly. Yeah. So tell us a little bit more. You're enjoying your second year, and you're doing neurology.
Yep. I'm on
And
neurology now. Mhm.
yep. And neurosurgery is where you want to go, eh? In when you graduate. That's kind
Yeah.
of how do you describe to our listeners how you get into the neurosurgery residency? I think you call it. You call it a residency when you graduate your 4 years. Step us through the process of becoming a neurosurgeon in the US.
So in the US, it's a pretty complex process. You have to go to medical school first, and get good grades along the way, get good board scores, and also you want to get as much research and experience in the field as you can. So research is very important in differentiating yourself, because you'll have a lot of people that have really good step scores. Step is our licensing exam, and they'll have really good step scores and have really competitive applications, but research is really kind of the big area where you're able to differentiate yourself, and programs want people who are productive in the research department, especially because most of the neurosurgery programs are at big academic centers. And kind of your whole application, your whole picture really gets taken into view, and then they'll select you from there. So they'll form a rank list, and you form a rank list as well based off places that interviewed you. And from there, there's a computer algorithm in the US that will match you with the programs that want you the most. So there's a little bit of chance involved.
All right. So um, it really it really starts from when you start medical school. Um, that determines your acceptance into a neurosurgical residency from year one.
Yeah.
And does neurosurgery residency require, say, a higher score or grades than, say, being an anaesthetist or a physician, or or an orthopedic surgeon? Like, how do they rank that grading system? Like, why would it be different to becoming a gastroenterologist, for example?
So I think the difference really relies upon what programs want, and there's such a finite amount of programs for neurosurgery that here in the U.S. it tends to be the higher scoring applicants on your board exams, and relative to anesthesiology is another relatively higher board score. I believe it's lower than neurosurgery, but it's still in the upper range of board scores. Orthopedic surgery is just about as competitive as neurological surgery here in the US.
Okay.
So you'll be
Okay.
seeing board scores
So
there.
does that mean that lots of people want to become neurosurgeons and orthopedic surgeons? Or does that just mean that there's not many spaces available to teach people to become to do those types of specialties?
So there's definitely a lot of people that want to join the field. I think the biggest problem is people kind of realize the barrier to entry is very high. And there's definitely a big obstacle to get through with the relative lack of programs as well in the US. I believe there's under 300 spots every year in the US, and
Wow.
there's going to be over 600 applicants. So the match rate is relatively low.
Yeah. Getcha. And what appeals to you about the specialty of surgery in general? What is that? Did you
I've
catch
always
that?
loved,
Oh, sorry.
yeah, no worries. I've always loved being in the operating room. I got my first experience when I was in high school. I had a summer internship program where I was able to shadow and work with a neurosurgeon who I became very close with, and I still do research and projects with
All
to
right.
this day. I've been grateful for his mentorship and all the
Super.
experiences I've gained with him. And I think what really defined neurosurgery specifically for me versus other surgeries was I just love the spine. I love the procedure and the
Awesome.
bones, nerve, and muscle all in the same area and how they can affect really the whole body and functional movement overall is really important to me. And I think that's definitely the area I could see myself working in for the rest of my life.
Brilliant. That's fantastic. And what projects have you done with that fellow? What type of uh, projects have you worked on?
A lot of quality outcomes projects, specifically in relation to spondylolisthesis, has been an area of research that I've probably been most involved in. Other than that, I've done a few projects on just spinal stenosis in general, or compared to more so interviewing. Or my most recent project we started was working with looking at the coflex, comparing that to decompression and fusion overall outcomes in relation to back pain with that procedure.
Yeah. Okay. Yeah. So so maybe just for our listeners who may not understand some of those terms, spondylolisthesis means a malalignment or an instability between two of the vertebrae. And if we talk, it's most commonly problematic in the lumbar spine. And there's various causes for the spondylolisthesis. And what can happen in the condition of spondylolisthesis is you can get a lot of mechanical back pain because the spinal vertebrae are not aligned well. And as a consequence of that, you can also then get neural impingement. And so that then leads to neuropathic symptoms radiating down the lower limb, motor sensory deficits. And then in regards to resolving that problem, often a structural intervention is required to restore spinal stability and decompress neural elements. And one of the most common procedures is called the posterior lumbar interbody fusion augmented with pedicle screw fixation and bone grafting. Okay, so those are big operations. They're challenging. They're expensive. They're dangerous. It takes patients a long time to recover from those operations. And so my most important message to people who have back pain and are susceptible to developing spondylolisthesis is to do everything you can to try to avoid the need for surgery, which is a 100% structural intervention. And if you're going to avoid the need for a structural intervention, you have to maximize your functional proficiency, And a lot of people don't understand what that means. And a lot of the industry does not spend enough time talking to patients about functional proficiency of the lumbopelvic spine. And so that's kind of it's not a new, my passion in the later part of my career is, I've learned how to do all the structural interventions, but now it's about, okay, what can we do to help people with spinal problems prevent the need for the surgery? One of the things I say to my patients, as a surgeon, my most valuable contribution to society is to teach people how to prevent the need for surgical interventions. Okay, we are trained as surgeons, but the most valuable thing that we can do to help people is teach them how to not need surgery. Okay, and if patients end up needing surgery, then the medical profession hasn't done its job effectively, including surgeons and doctors and GPs and physical therapists. We should be able to massively reduce the requirement for surgery, and in some ways, I'm trying to do us out of a job.
Exactly.
I'm trying to put ourselves out of business, really. From a practical point of view, there's still going to be a lot of work because people still have accidents, people still fall down the stairs, and people still get hit by cars and injure themselves in that way. But the massive majority of the work that spinal surgeons do is not because of accidental spine trauma. The massive, like, I don't know, 99% of work that spinal surgeons do is due to chronic accumulation of that structural deterioration. So yeah, that's just a couple of little thoughts there. What was the other word you used? Spondylolisthesis, and then you used Coflex. So tell us a little bit about Coflex.
So Coflex is an interlaminar stabilization device. Basically, it can be used in
Oh, you're just breaking up there.
an alternative to a fusion procedure.
Jeff, just start that again. I think the Zoom gremlins just froze for a second.
Yeah, no worries. So the Coflex is a interlaminar support device that can be used as a replacement or as an alternative, really, to fusion in decompression surgeries in spinal stenosis. So basically, the goal of it is to have a less invasive operation than a fusion, and try to have patients to allow similar recovery after procedures.
Yeah. And it's a relatively minimally invasive procedure. It's not a quite small incisions, minimally traumatic to the paraspinal soft tissues. And there's a small device that sort of gets slotted into the interspinous position. As I recall, I think I've done one of those procedures many years ago. We actually had those devices in Australia some time ago. But what's your experience with it? Like, tell us what you've studied and found out.
So the interspinous devices, yeah, you guys definitely had long before we saw here in the US. So the Coflex is a little bit different than the interspinous devices because it goes in between the lamina and the interspine. So it'll go a little bit further in. It's a little bit more invasive, but it'll still have significantly less blood loss than the interspinous devices. So we did a little review of sort of all available literature in the last about 10, 15 years or so on interspinous devices and Coflex, comparing that to fusion and decompression. So some notable findings. We haven't published the paper yet, but hopefully soon.
Sure.
and we noticed there's a much higher reoperation rate in regards to interspinous devices compared to fusion or decompression. And then Coflex, it was noticeably higher, but it still wasn't statistically significant. But I always kind of found trouble with the term statistically significant in medicine, just because of how, just because something is happening more, the fact that statistics say it's not significant, I don't really know if that's as true as, because if we're giving a patient a device and they need to have reoperations more often, I'm not sure if I want to keep giving that patient that device. So, but
Sure.
overall, in patients that didn't have to undergo reoperation, we saw equal outcomes in terms of improving back pain compared to fusion and decompression.
Okay, fantastic. And does the Coflex device that you're using, does it create a fusion? Is there some elements on the device that create fusion or integration of the device into the bone, or not? No.
Not that I believe so.
Okay. So it kind of unloads the facet joints and creates a little bit more room within the spinal canal. It opens up the caliber of the spinal canal to allow improved microcirculation to the neural elements, and hence the clinical benefit that you see.
Exactly.
Wonderful, wonderful. Okay. Now, have you heard or read or seen much of the work that we're doing in Brisbane in regards to functional movement focused rehabilitation?
Absolutely. Very interesting to read, because you don't
And
really see it.
what platforms have you seen or heard about our work in Brisbane?
Instagram, YouTube, all been, I think Twitter. You guys are on Twitter as well? Definitely seen
Okay. Yep.
stuff
And
shared
the
on Twitter.
YouTube. Yeah. So just to give a bit of a indication of some of our work, we do have a YouTube channel. It's called Functional Movement Training Center. We do have an Instagram page. It's called NeuroHAB Movement Therapy. So anyone who's listening, we're delighted for you to follow our work there, and also comment with your experiences, because ultimately the only way we're going to try to make some differences here is if we adopt this grassroots approach. A lot of the industry is a bit reluctant to change, and it's not until people start kind of demanding something that's more effective that the industry will sway towards that, because currently the industry is very symptom and structure focused, as opposed to cause and function focused. Okay, so and as a profession, we're very good at salvaging people when they need an invasive operation, Coflex, spondylolisthesis, decompression surgery, microdiscectomy, realignment procedures. But that's kind of like the end of the line, and we really haven't done a good job. Whereas we can save billions, literally billions of dollars, if we start teaching people when they get their niggly spine pain, when they get a little bit of a back spasm, what is driving those symptoms in the very early stages of that journey. If we implement effective rehabilitation right from the get-go, those patients will never come to need a scalpel or surgical intervention. And that's really the essence of our objectives, is to make people understand that there are more effective rehabilitation methodologies that do address the root cause of why their spine health is deteriorating. So, so for those patients, do you get an opportunity, or does your surgeon mentor get an opportunity to entertain those discussions with patients, when they've got spinal stenosis and when they've got claudication, which means pain down both legs, or when they've got a lot of back pain? Do you hear people talking about what causes those symptoms in the first place? Tell us your
Yeah,
experience there.
absolutely. I think it's definitely something I've seen more increase over the last few years, and it's something that's always kind of left questions for me when we do these papers. Is why aren't we comparing these patients to patients who undergo only conservative therapy? And I think that's something that's always interested me and something that I brought up and would love to add to my papers in the future.
Mm.
Um,
Yeah.
but it's definitely something we've mentioned a lot. And one of my mentors who I was recently connected with through my school he's written a book called The End of Back Pain. His name is Dr. Patrick Roth. It's a
Wonderful.
great, and he outlines a whole movement therapy for his patients, mainly in the use of kettlebells in hopes of
Yeah.
reducing the incidence
Great.
of back
Oh, look, hey, can you put me in touch with him? I'd love to
course.
meet him. His book's called The End of Back Pain. I'm going to look that up. We'll look that up. Have you got a copy?
I do. Yep.
You've read it. Okay. I'll source it out. And so what is the essence of it? What is, you say kettlebells? I love that. As a first, immediately you're starting to think of movement proficiency when you swing
Mhm.
a kettlebell, right? And okay, tell us a little bit more about that.
Yeah, exactly. So it's exactly what you said. It's movement proficiency, and it's increasing core strength, back strength, and just overall movement and ability for these patients. And a lot of them come in raving about it. And he is definitely not. Surgery is definitely not his first option for all of his patients.
Yes.
And
Wonderful. Does he have a rehabilitation center like we do, or does he just does he just refer people out to personal trainers? How does he sort of triage and work his patients through the journey?
he'll refer out to physical therapy for the most part. I believe his practice might have some physical therapy, but not on the level of CrossFit Neuro.
Okay, okay. Yeah, we're so fortunate that I can see a patient in my office. And remember when they get referred to a neurosurgeon, average time of back pain is 2 years. Okay, so they've been out there in the wilderness, uh, suffering from back pain for 2 years before they return to their primary care physician, their GP, and say, "I'm not getting better. I'm getting worse. I've spent countless hours with the physical therapist receiving massage, Pilates, dry needling, acupuncture, uh, adjustments, and I'm still getting worse day by day. I'm now on 3 different pain medications. So what does the primary care physician say? Well, okay, time to go and see the neurosurgeon. You've got chronic pain. You might need an operation because that's what they think as patients complain of ongoing worsening symptoms. And like I said, our job as clinicians is to prevent people needing surgery. So when they come and see me, of course, I look at the structural integrity of the spine. I get an MRI scan more often than not. And I say, well, look, if you don't start doing the right thing now, yes, you are going to need surgery. But 9 out of 10 patients we can salvage before they need surgery. We can salvage them. Um, when I'm in surgery 1 or 2 days a week, it's for those unfortunate people that have left it a bit too late, not due to their own fault, but due to the fault of the industry. And their structural deterioration is so far advanced that now they need a structural intervention. 9 out of 10 people, we implement, like the fellow who's written the book, we implement the functional intervention, and all of a sudden the pain symptoms start to settle down. Because what are we doing when we introduce a functional intervention? We are upskilling the patient's movement. So when we upskill movement, we reduce biomechanical stress on the spinal motion segments. We reduce inflammation and nociception. And when we reduce inflammation, we're preventing the accelerated deterioration of the joints. And when we prevent the accelerated deterioration of the joints, we mitigate the need for a structural intervention because the joints are now just traveling along at the normal pace of degeneration, right? And degeneration is a normal pain-free process that should carry us through for 105 years. Okay, and then we just die in our sleep if we do the right things in life. Right? But it's hard to get the industry to deliver functional interventions because it's much easier to lie them down on a couch and deep tissue release, and it's much easier to just have them do passive things and let the therapist do his magic hands work, as opposed to train someone to move well. That's hard work for both the patient and it's hard work for the therapist, but the payoffs are exponentially orders of magnitude more valuable. So I want you to think about movement dysfunction as being a disease, Jeff. When someone comes and says to you, why do I have back pain? The overlying disease process is movement dysfunction. Okay, so I qualify that as at the top of the hierarchy. And then movement dysfunction can drive all of the underlying secondary structural symptomatic conditions which have clinical symptoms. So movement dysfunction can drive sacroiliac joint dysfunction, can drive facet joint syndrome, can drive annular tears in the discs, can drive the development of a disc prolapse, will develop facet hypertrophy, will then develop spinal stenosis. All of those things are secondary factors. And if we reverse engineer the problem and go back to movement dysfunction and we deliver movement therapy, bingo, you've fixed the cause of the problem. It's not rocket surgery. Okay, it's not a difficult concept for people to understand. It just needs that paradigm shift in thinking, and I'm so excited that that you're thinking that way. That's superb. It's superb. Always think about that when you're doing your, highly complex surgeries in the future. Is that if I did the right thing 5 or 10 years ago, this person wouldn't be on the operating table now. Does that resonate?
Absolutely, definitely. I think preventing surgeries is absolutely the most important part of being a surgeon, I think.
Yeah. Awesome. All right, mate. Anything else you want to chat about, or I'm happy to chat later on. Have some more calls. Any sort of questions that you have of me from your end, or?
No, not right now. I think maybe, what do you think you could go back and see yourself as a medical student, however many years ago that was? Well,
yeah, well, look, well, you just froze up there. I heard your question. When you're going through med school, you are kind of learning how to be the lifeguard, salvaging people when they're in intensive care unit, and that's very important as well. But as going through as a medical student, we're not really thinking about being the swimming coaches, which is teaching people to not drown in the first place. And that's a Greg Glassmanism, who the founder of CrossFit. We need to teach more swim coaches, not more lifeguards. Okay. And it's a very profound metaphor. But yeah, that's all I would think. I would sort of focus, if I could go back to my medical student days, I would ask more questions of my lecturers and my mentors back in the day that were teaching me to be a lifeguard. And I would be provoking my fellow students and my mentors to start making us think as a group about being swim coaches. And if we could get all doctors thinking like that, then the whole expenditure on chronic disease would be effectively addressed, right? We would start to make amends. That it's almost 15 to 20% of total government expenditure is spent on health, and most of that, 90% of that expenditure, is on chronic disease. So it's more than billions of dollars, Jeff. It's trillions. It's trillions. And if we just made a slight improvement in our approach to medicine, think how much money we could spend on other things. Like, think how improved our society would be if we had trillions of dollars to spend on schools, on the environment, on beautifying the world, and nurturing children and those unfortunate people who are disabled and need more help. My God, the world would be an incredibly different place. and it is in the palm of our hands, but as a profession, we're kind of dropping the ball at the moment, I really think. And so good to see people like yourself, Jeff. You're going to be future leader. Okay, you're going to be a future leader, and let's stay in contact. I'd definitely want to meet. I definitely want to get in touch with your mentor and the fellow who wrote that book. So we'll email each other later, because I want some international ambassadors of functional movement therapy, international ambassadors, to be part of the new College of Functional Movement Clinicians. Okay, you've got the College of Surgeons, you've got the College of this and that, but we now have a College of Movement Clinicians. Okay, I think our time is about to run out.
Yeah, 1 minute left.
I think we're going to run out of time pretty soon. We'll talk again, Jeff. Thanks for having the conversation, and we'll talk soon.
Thank you so much. Thanks for having me on.